Hello, my name is Wenhui Zhou. On behalf of my co-authors, I would like to discuss key finding from our manuscript titled Thermal Ablation of Renal Cell Carcinoma in Morbidly Obese Patients, Assessments of Technical Results, Procedural Safety, and Oncological Outcomes. We have no financial disclosure. With a large prevalence of obesity worldwide, there is a subset of obesity defined by a body mass index greater or equal to 40, known as morbid obesity. There are significant technical challenges when performing medical procedures on these patients. In fact, for a wide range of surgical interventions, morbid obesity is considered a relative contraindication. In the case for surgical nephrectomy of renal cell carcinoma, or RCC, results from over a dozen publications show that morbidly obese patients are poor candidates for nephrectomy due to increased surgical complications and adverse outcomes. Therefore, the minimally invasive technique of renal ablation may be ideal for treatment of RCC in these patients by overcoming both challenging anatomy and complex medical comorbidities. Despite strong evidence of the safety and clinical benefits of renal ablation in the general population, its utility in morbidly obese patients remains unclear. The goal of this study is to investigate the impact of morbid obesity on procedural outcome and treatment efficacy of renal ablation for localized T1 RCC. Here's a chart to explain our study design. This is a retrospective analysis including 107 patients who underwent CT-guided renal ablation for clinical stage T1 N0M0 biopsy-proven RCC. There were 34 patients in the morbid obesity group, again defined as patients with a BMI greater or equal to 40, compared to 73 patients in the normal weight group, defined as patient with a BMI less than 25. Pre, intra, and post-procedural imaging studies were reviewed to identify differences in the baseline characteristics as well as various clinical outcomes. For outcome analysis, we assessed technical outcomes, which include ablation time, procedural time, anesthesia medication dosage, and radiation exposure. For procedural safety, we assessed immediate and peri-procedural complication using the SIR guidelines. For oncological outcome, we assessed residual disease and local recurrence on surveillance imaging and calculated cancer-related survival. Without going into details, here is the statistical analyses utilized in the studies. This table summarizes the patients and tumor characteristics in our study. Baseline patient and tumor characteristics were overall similar between the two groups, with two exceptions. As expected, the median Charlson comorbidity index was significantly higher in the morbidly obese group, average 4.2, compared to the normal weight group, average 3.1. Interestingly, there was an increased number of high renal score tumors in morbidly obese patients. This increased tumor complexity may predispose these patients to increased rates of complication. Procedural outcomes are summarized in this table. In our study, CT-guided renal ablation was successfully performed in all morbidly obese patients with 100% technical success. Mean ablation time was similar between the morbidly obese and normal weight groups. Notably, mean procedural time was significantly longer in the morbidly obese group when compared to the normal weight group. This finding may reflect the additional time required to accommodate morbidly obese patients in the IR suite, which may go to room and equipment setup or patient positioning. Additionally, the morbidly obese group was associated with increased fentanyl and midazolam usage, as well as higher radiation exposure. These findings were not unexpected because all of these parameters were dependent on body weight. Procedural safety and oncological outcomes are summarized in this table. Compared to normal weight patients, morbidly obese patients have a significantly higher incidence of perinephric hematoma, 9% versus 1%. 3 of these hematoma in morbidly obese patients were major complications, requiring blood transfusion. Several patient risk factors, such as higher prevalence of hypertension, may explain this increased risk of peri-procedural bleeding observed in the morbidly obese patients. Looking at other complications, we found that the rate of ureter and bowel injuries were minimal and similar between the two patient groups. Regarding treatment outcomes, at 1-month follow-up, there was no differences in the treatment efficacy and the corresponding rate of residual disease. At 5-year imaging follow-up, local recurrence was observed in 15% of the morbidly obese patients, compared to 8% of the normal weight patients. However, this difference was not statistically significant. No metastatic disease or RCC-related death was observed in either patient group. This figure shows Kaplan-Meier graphs comparing cancer-related outcomes between morbidly obese and normal weight patients. Overall, there was no significant difference in RCC-specific cancer-free survival, disease-free survival, or metastatic-free survival between the morbidly obese and normal weight patient groups following renal ablation. To identify a predictor for poor treatment outcomes, we perform univariable and multivariable logistic regressional analyses as shown in these tables. Specifically, our analyses show that both larger tumor size and higher renal nephrometry scores are associated with increased risk of complications and residual disease. These findings were consistent with prior reports, supporting the utility of these metrics for pre-treatment planning in morbidly obese patients. Before going into the main conclusions, we want to discuss the limitations of our study. First, this study is retrospective and non-randomized, which limits the strength of our findings. Additionally, the results of the present study may not be generally applicable in every ablation practice, because this is a single institutional study from a high-volume center with over 20 years of experience with renal tumor ablation. Second, compared to the normal weight cohort, there are fewer patients within the morbidly obese cohort of this study. This small sample size could be overcome with a multi-institutional registry or meta-analysis, which could help to address potential bias and to increase the statistical power to detect outcome differences between the two groups. Third, the present study did not directly compare renal ablation and nephrectomy. Despite our encouraging results, a prospective clinical trial is necessary to investigate the merits and limitations of each approach in morbidly obese patients. What did we learn from the study? Our study demonstrated that renal ablation is feasible and effective in morbidly obese patients, resulting in similar rates of technical success, primary treatment efficacy, and cancer-related outcomes as those achieved in normal weight patients. When performing renal ablation in morbidly obese patients, it is important to acknowledge the increased procedural time, anesthesia medication dosage, and radiation exposure associated with this population of patients. While procedural complications overall compare favorably to those reported in the nephrectomy literature, morbidly obese patients are predisposed to a higher incidence of perinephric hematoma compared to normal weight patients. Assessments of the tumor size and renal nephrometry score could be helpful for treatment planning in these patient population. Overall, our data provide a strong rationale for offering RCC ablation to morbidly obese patients who otherwise have limited treatment options. Our hope is that this paper will provide a point of reference for individualized treatment planning and patient counseling when performing renal ablation in the morbidly obese population. On behalf of the co-authors, thank you for your time and attention.